So welcome to this Child Sim Talk Plus. So today we are very privileged to have Dr. Tom Yang coming to Hong Kong Children's Hospital to deliver this very special talk. Many of you might know that Tom actually is the founding author of the Neonates that we have been using since we were junior doctors, because he wrote a book for almost like a 26th edition before it changed to another format. Tom is also one of our best friends. We just remember that he came to Hong Kong shortly before the changeover in 1997 as our first guest of the Hong Kong Neonatal Society. The other thing that we remember Tom is that the way he contributed to our TPN system by giving us the free version to help us to give TPN, prepare TPN for our sick neonates. But today he is going to talk about using pharmacokinetics and pharmacodynamics to guide us using antibiotic in neonates. So without further ado, may I invite Tom to deliver his talk.
Thank you, Bill. I always enjoy coming to Hong Kong. It's a special place, and I have special friends here, and so it's a privilege, and thank you for the opportunity to let me give you this lecture. As Bill said, I co-authored Neonates for a number of years, and recently I've been doing more teaching and looking at how people use and deliver drugs. Part of that is the explosion in information about pharmacokinetics and pharmacodynamics in newborns, and so I'm happy to share some of that newer information with you. So just to review, pharmacodynamics is the study of the effect that drugs have on the body, with a particular emphasis in the dose-response relationship. Pharmacokinetics is the study of the way in which drugs move through the body via absorption, distribution, metabolism, and excretion. So for the purposes of this talk, I want to stick to antibiotics because antibiotics are the most frequently used drugs in the NICU. What's always striking to me when I go to various hospitals in my area of the United States, or when I go around the United States, or when I visit other countries, that the prescribing practices vary quite considerably, both on when antibiotics are used and the dosing regimens that are employed in each hospital. So we know that infections are not frequent in NICUs, and hopefully everybody's working very hard to diminish the number of infections, but every infection has a large impact on the outcome of babies. So our pharmacokinetic targets depend on the mechanism of action of each antibiotics, and the goals being to maximize the efficacy, to minimize the toxicity. So let's break antibiotics up by types. One group is the beta-lactams, which are the penicillins, the cephalosporins, and the carbapenems. And the bacterial killing is related specifically to the time above the minimum inhibitory concentration. This differs from aminoglycosides, such as gentamicin and amikacin, where the bacterial killing is related specifically to the peak concentration. And then there's vancomycin, which is a drug we've been using for a long time but are still learning what the best way to deliver vancomycin is. And we think the vancomycin killing, the bacterial killing of vancomycin, is related to the area under the curve to the minimum inhibitory concentration ratio being approximately over 400, and I'll explain that more later. Babies are special. Neonates are in a unique and dynamic pharmacokinetic state with rapid changes going on due to maturation. And these changes affect drug absorption, distribution, metabolism, and excretion. The strongest influences on pharmacokinetics in neonates are related to gestational age, postnatal age, birth weight, and serum creatinine. So this will be a little bit of a review of pharmacology. So let's first talk about volume of distribution. So neonates, especially preterm neonates, have a relatively high proportion of total body water and a low proportion of total body fat. So what does that mean for volume of distribution? Well, the volume of distribution is increased for water-soluble drugs, which includes most antibiotics. On the other hand, volume of distribution is decreased for fat-soluble drugs, which includes most drugs related to the central nervous system. And the high brain-to-body mass ratio means that lipid-soluble drugs have a relatively higher concentration in the central nervous system in neonates compared to adults. What about volume of distribution in disease? Well, babies who have true sepsis and those with large patent ductus arteriosus, the volume of distribution is going to be increased. The volume of distribution is also altered during therapeutic hypothermia due to changes in renal blood flow. It'll have a different effect on different drugs, so that, for example, phenobarbital and midazolam, there's an increased volume of distribution. But for drugs such as morphine and fentanyl, there's a decreased volume of distribution. What about protein binding? All neonates have decreased protein binding of drugs due to smaller amounts of serum albumin, serum globulins, and total body protein. Therefore, the relative amount of unbound or free drug is increased so that neonates will have more effects than adults will with the same total drug concentration. The clearance of drugs is prolonged compared to adults and children. 1, due to immature hepatic metabolism, and 2, immature renal excretion, which is most important for antibiotics. So renal excretion is both gestational age and postnatal age dependent, and this effects will be exaggerated in babies with intrauterine growth restriction because of altered renal morphogenesis. So the prolonged drug clearance will lead to higher drug concentrations, as well as higher metabolite concentrations and the potential for drug accumulation. So here's an example of postnatal maturation of glomerular filtration, and this is an older slide, but this is birth weight and postnatal age and their effects on GFR in the first 2 weeks of life. So the lower line here is babies between 1,000 and 1,500 grams. The upper line is term babies, and then the 2 lines in between are the larger preterm babies. But you can see from 1 to 2 days of age up to 15 to 16 days of age, a change in GFR. For preterm babies, the smaller preterm babies from 1,000 to 1,500 grams, even at 2 weeks of age, their GFR is lower than a term baby in the first few days of life. That is why we have longer dosing intervals for preterm babies for prolonged periods of time. Another way of displaying this is to look at babies at day 7 of life, over here in this red circle, and compare the GFR for preterm babies to a term baby at birth and a term baby at 7 days of age. And you can see that even with this gradual increase in GFR, it still remains below term for at least 2 weeks. There are also effects of drugs on renal drug excretion. So, for example, babies receiving ibuprofen will have altered renal drug excretion. Ibuprofen will decrease drug excretion by 20%. And when we used to use indomethacin, it had a much larger effect, even up to 40% on renal drug excretion. But even with all the modeling and all the research into neonatal drug excretion, you can find that there's a huge amount of variability, and so that standard dosing remains very difficult, and therapeutic drug monitoring, TDM, remains very important for many drugs due to this large intrapatient variability. So here's an example of amikacin clearance at postmenstrual age 24 weeks up through term, and you can see that even with a clustering around a central line, you can see large variations at each postmenstrual age. Some relatively recent information on ampicillin pharmacodynamics. Remember that it's a beta-lactam antibiotic, and therefore the efficacy is related to the time above the MIC. In a POPS study model, MICs that were used were 2 micrograms per ml for listeria and 8 micrograms per ml for E. coli. Because of these targets that were used, the goal was to have a concentration above 8 micrograms per ml 90% of the time during the dosing interval. You can see that ampicillin half-life varied with postmenstrual age, being very long. Over here at 26 weeks, it was approximately 7 hours. When you got down to 35 weeks, the half-life is now about 4 hours. Therefore, based on this POP study that was done, they came up with a dosing regimen for ampicillin with gestational age over here on the left, and then the different postnatal ages. And you range from 50 milligrams every 12 hours to 50 milligrams every 8 hours, depending on the gestational and postnatal age. You can take that same data and come up with different standardized dosing regimens and reach similar targets, but nonetheless, this is the best fit for their data in this study, and it's a valid recommendation. What about cefotaxime? Well, cefotaxime has time-dependent bacterial killing. The drug is eliminated by the kidneys about 70%. Most susceptible pathogens have MICs less than 4 micrograms per ml. So in these studies, the goal was to maintain the serum concentration above the MIC for at least 60 to 70% of the dosing interval due to reduced immunocompetence in neonates, especially preterms. So if you read adult studies, oftentimes they'll say they would like to keep the serum concentration above the MIC for approximately 50% of the time. Neonatal authors will take that information and alter it and make it 60 to 75%, and in some cases they'll even go as high as 80 or 90%. Those are arbitrary numbers, but the idea is that we have to alter our goals for neonates. So using different dosing intervals, they looked at how often or how much time would be above the target for different doses, and you can see the dosing interval down here with a unit dose of 50 milligrams per kilogram. If you dosed every 12 hours, it would only work in babies who were less than 32 weeks and less than 7 days of age. If you wanted to dose older babies, you'd have to do it more frequently, even every 8 hours, to reach your target levels. So again, they took their data and said if you dosed 50 milligrams per kilogram for all neonates, these are the dosing intervals that were recommended. So every 12 hours for all babies less than 7 days of age, every 8 hours for preterm babies greater than 7 days of age, and every 6 hours for older preterm babies older than 7 days of age. And the model was valid up to patients to 44 weeks postmenstrual age. Meropenem has gotten a lot of research and publications in the last few years. It's a drug that's used with increasing frequency because of multi-resistant organisms. So we need to know that, one, meropenem exhibits time-dependent killing of bacteria. And the goal, and again in adults, is to keep plasma concentrations above the MIC for 40 to 50% of the dosing interval. But again, we're going to alter that for preterm babies with a therapeutic target above the MIC for 75% of the dosing interval. And even then, they felt that for Pseudomonas infections, you should be above the MIC for over 80% of the dosing interval. And that's assuming that the Pseudomonas MIC is 2 micrograms per ml. If the MIC was higher, that would change. So for their studies, the pharmacodynamic target exposure level was 4 micrograms per ml for 50% of the dosing interval and 2 micrograms per ml for at least 75% of the dosing interval. So PK studies have shown that prolonged infusion times for 3 to 4 hours will produce drug concentrations above the MIC for more of the dosing interval, especially against organisms with high MICs. So traditionally we've been dosing meropenem and infusing over 30 minutes. that may work for some infections, but for more severe infections, this prolonged infusion has at least pharmacodynamic and pharmacokinetic rationale for using it. So if you're treating serious infections caused by gram-negative bacilli with MICs in the 2 to 4 microgram per ml range, I would strongly consider using the prolonged infusion times. This is a study from 2017 looking at bolus dosing versus continuous infusions, both at 20 milligrams per kilogram doses and 40 milligram per kilogram doses. And you can see for every dose that the continuous infusion stayed above the MIC longer excuse me, than the bolus dosing. The first clinical study that actually looked at outcomes rather than just pharmacokinetic data came out 2 years ago, and this actually showed better clinical outcomes with the 4-hour infusions. So here's the conventional group, which was infused over 30 minutes, versus the infusion group, which was over 4 hours. And you can see that neonatal mortality was decreased, clinical improvement was increased, the duration of respiratory support was diminished. And when they followed C-reactive protein as a guide to response to therapy, the CRPs were lower after the intervention. So in their study, and this is from Turkey, I believe, they found that better outcomes with the 4-hour infusions. Is there a downside to prolonged infusions? And the answer is yes. The central nervous system concentrations are actually lower. You have, because because the peak serum concentrations correlate with CNS concentrations, when you give the prolonged infusion, your peak concentration is less, and therefore your CNS concentration is less. Therefore, if you have a patient with meningitis, you should use the higher doses, the 40 milligram per kilogram dose, or use the shorter infusion times. These are the best recommendations that we can find now. These are from Brian Smith from 2011. So for these gestational age breaks, these postnatal age breaks, so greater and less than 32 weeks, greater than less than 14 days of age, they use these doses. Based on the information I just showed you, for meningitis, the dose should be increased from 20 to 30 milligrams per kilogram to 40 milligrams per kilogram. Or if your MIC for your organism, especially for Pseudomonas, is 4 milligrams per liter, the dose should also be increased to 40 milligrams per kilogram. Aminoglycosides, another group of drugs we've been using for a long time. They are most often used in conjunction with a beta-lactam or a carbapenem. You hardly ever use an aminoglycoside by itself. Therefore, clinical outcome studies of patients treated with aminoglycosides alone are lacking. We primarily monitor serum concentrations for toxicity, but also we're monitoring peak concentrations for the presumed efficacy based on bacterial killing studies. Remember that aminoglycosides are different in that bacterial killing is concentration dependent, and the therapeutic efficacy occurs when the peak concentration, or the Cmax, to the MIC ratio is greater than 8 to 10. The greatest bacterial killing from aminoglycosides is with the first exposure to the drug, and that comes into play with how you dose. Also remember that aminoglycosides are water-soluble and pass through the lipid cell membranes better after disruption, so that the synergy with drugs that disrupt cell walls, like penicillins or cephalosporins, occurs. So you have the lipid cell membrane being disrupted by the penicillins and the cephalosporins, and then the aminoglycosides pass into the cell and do bacterial killing. We also know that aminoglycosides will have this synergistic effect even with low concentrations. But again, there are no outcome studies looking at that specifically. When should we measure peak concentrations? I recommend measuring peak concentrations in neonates for those babies who have proven sepsis with pneumonia, because the peak serum concentration, the Cmax, is needed for tissue penetration, especially into the lung. I also recommend measuring peak concentrations for seriously ill babies with sepsis and PDA, because if you recall from one of my earlier slides, the volume of distribution is increased, and that large volume of distribution will actually decrease your peak serum concentration. Using the MIC for the different organisms, for gentamicin, if the MIC is 1, then the target should be 8 to 10 mics per ml for a peak serum concentration. For amikacin, if the MIC is 3, then the target Cmax should be 24 to 30 micrograms per ml. So again, your target is based on the MIC of the organism and the drug that you're using. There's something called the post-antibiotic effect for aminoglycosides. We know that there are genetic alterations in bacteria that occur during treatment. And after the initial rapid killing during the time of peak concentration, the drug is actively transported into the cell, which triggers the second phase of bacterial killing. But there's an adaptive resistance that occurs in bacteria due to downregulation of this active transport into the cell. And so as the drug concentration decreases, this adaptive resistance decreases. Higher peak concentrations are associated with longer post-antibiotic effects, and the longer dosing intervals that we now use for aminoglycosides lead to less chance for bacterial resistance. Aminoglycosides are 90% eliminated unchanged by the kidney, so very little metabolism occurs. There's no reabsorption or active secretion, and therefore the clearance is directly related to the GFR. So we know that GFR in the first week correlates with gestational age, and that after the first week of life, GFR correlates with postmenstrual age, or a combination of the current weight and the postnatal age. So different pharmacokinetic models will use one or the other. Despite the concerns about renal toxicity, it is usually not significant in neonates unless there is a significant overdose that occurs. But we do know that there can be some proximal tubular dysfunction, which is measured by enzyme electrolyte excretion in the urine, and that's related to the time that the renal tubule is exposed to elevated drug concentrations. So the dose of aminoglycosides, such as amikacin, is determined by the volume of distribution. So here's a study from several years ago from Carl Allegert, and you can see that the volume of distribution over here on the left is directly related to gestational age. And it is the largest per kilo in the smallest babies. So here at less than 28 weeks, it's 0.7 liters per kilo. At term, it's down to 0.52 liters per kilo. Therefore, the dose needed to reach the same peak concentration is proportionally larger in the smaller babies. So with this volume of distribution, you would need 20 milligrams per kilogram. For this volume of distribution, you would only need 15 or so. The dosing interval of aminoglycosides is specifically related to clearance and GFR. Excuse me. And so the clearance here you can see is the lowest in the smallest premature babies, and therefore they have the longest dosing interval. And again, as you get close to term, the dosing interval goes down. So there are several guidelines used for aminoglycoside dosing. This pharmacokinetic model from Belgium, you can see that they have dosing intervals such as 48, 42, 36, and 30 hours, and even 20 hours in older babies. Some nurseries find these dosing intervals difficult to deal with because they're not necessarily standard across the hospital, and so you can use the same pharmacokinetic data and come up with other dosing intervals. Here's one here from 2017 that used similar data, and you can see that the dosing intervals are now 48, 36, and 24 hours with doses in the 12 to 14 milligram per kilogram range. What's striking to me, and if you read enough of these studies, here you can see you have doses in the 15 to 16 milligram per kilogram range. Here you have doses in the 12 to 14 milligram per kilogram range. And depending on the population, you're going to see very similar levels. And so TDM is important and recommended for babies who receive aminoglycosides for more than 48 hours. A third study, again, was similar. Now they used 13 milligrams per kilogram as a standard dose for everyone and came up with these dosing intervals. This is from Korea. So I said we should do TDM for aminoglycosides for babies who are being treated for more than 2 or 3 days. And remember that the toxicity is related to elevated trough concentrations. It was thought in the past that the target trough concentration to decrease both renal and ototoxicity would be less than 2 mics per ml for gentamicin and less than 5 mics per ml for amikacin. But now we consider those too high, and the target should be less than 1 microgram per ml for gentamicin and less than 3 micrograms per ml for amikacin. Why? 1 is the post-antibiotic effect that I mentioned before. 2 is the demonstration that adaptive resistance is higher with higher trough concentrations. And 3 is that there has now been enough clinical studies to show that the documented efficacy of prolonged dosing intervals, either 24 hours or greater. If you don't have a TDM service in your hospital, you can use guidelines such as this for how to monitor and alter dosing. So, for example, if you measured a amikacin concentration at 24 hours and it came out as somewhere between 5 and 8 mics per ml, you could predict that the half-life was about 12 hours, and therefore a suggested dosing interval would be 36 hours. So this is a rough guideline to use without having fancy pharmacokinetics or pharmacologists to help you out. Here's something similar for gentamicin. This is from the most recent edition of Neonates published by IBM and Micromedics. And you can see we have, based on postmenstrual age and postnatal age, doses and dosing intervals. A similar chart that we developed in Neonates was if you measure serum concentrations at 24 hours, you can predict what the half-life is, and therefore you can come up with a suggested dosing interval for that individual patient. Vancomycin. This is always the most fun. Excuse me. Vancomycin killing activity against Staphylococcus is a time-dependent process. So again, this is different than other antibiotics. Dosing and monitoring of vancomycin remains controversial. Why? Many people cannot agree on what a therapeutic trough concentration is. Why would that be? Well, it depends on the organism and it depends on the MIC of the organism, so therefore what you're treating determines what is a therapeutic trough. Should we measure peak concentrations? Well, they don't seem to correlate with efficacy and they don't seem to correlate with outcomes. Now some people are promoting the idea of measuring area under the curve to monitor vancomycin therapy. So the Infectious Disease Society of America, an organization in the U.S., recommends that, this is for adults, a target AUC to MIC value of 400 is needed to adequately treat serious staphylococcal infections, bacteremia, endocarditis, meningitis, etc. This is true if the MIC is less than or equal to 1 microgram per ml. If you have a staphylococcus infection where the MIC is 2 micrograms per ml or greater, then you either need to use an alternative drug or give an additional drug such as rifampin. Vancomycin alone would not likely to be able to treat this infection without toxicity. Back to adults. So for adults with normal renal function, a serum concentration of between 15 and 20 micrograms per ml fairly reliably predicted that the AUC to MIC ratio would be greater than 400, and if that was maintained at greater than 400, it was shown to modestly improve patient outcomes. So it's one of the few outcome studies, and one of the first outcome studies. This was published in 2011. Neonatal PK studies that have been done since that time suggest that lower trough levels, not 15 to 20, but something lower than that, would predict this ratio being greater than 400. However, we don't have any outcome studies in neonates that are treated using these recommendations. So despite some adult clinical outcome data, we don't have that for neonates. So a pharmacokinetic study done in infants comparing this AUC-MIC ratio to trough concentrations found that you could reach that target of 400 with an average trough concentration of roughly 9, which is significantly lower than the 15 that was promoted for adults. You have to love graphs like this. This is another graph showing neonatal variability. So it's vancomycin dosing, the AUC greater than 400, and trough concentration. So if you compare dose with versus AUC, here's the dotted line of 400 as your target, and with every 12-hour dosing or every 8-hour dosing, you were always above, almost always above 400. If you compared dose versus trough concentration when the AUC was greater than 400, you can see again all over the map trough concentrations ranging from 5 or 6 all the way up to above 15, depending on what the dose. This was just published last year. Again, remarkable variability in neonates. So there's some new concepts that have just come out in the last year or two about vancomycin. And one is the idea of using unbound vancomycin concentrations. So the available PK and PK data are based on total serum concentrations. All the things in the literature you're reading are all total concentrations. But we also know that unbound vancomycin is what leads to the pharmacologic effect and is subsequently available for elimination. So a study published last year shows that unbound concentrations in neonates are significantly higher than adults, and we would predict this based on the fact that we know that neonates have less protein binding. So in adults, in this study, total protein levels were at this level, and the unbound fraction of vancomycin was a mean of 62%. If you compare that to neonates with lower proteins, the unbound fraction was approximately 90%. So even though the total vancomycin concentration in adults averaged 18, and it was significantly lower in neonates, it was 14, the actual unbound concentration was higher in neonates than it was in adults. So if you do some math, the total concentration of 15 to 20, which was recommended to maintain the AUC over 400 in adults, correlates with an unbound concentration of 9 to 12 micrograms per ml. So if we take 9 to 12 micrograms per ml unbound in neonates, that turns into a total serum vancomycin concentration of 10 to 13. Therefore, if you're going to use trough concentrations to monitor neonates, 10 to 13 micrograms per ml should be adequate for efficacy and to lessen the chance of toxicity. You do not need to shoot for 15 to 20. 10 to 13 should be totally adequate. Now it gets even more complicated. So if we're trying to use the area under the curve to the MIC ratio in dosing, what should we use? Well, if the goal is 400, again assuming the MIC is 1, and we know that neonatal vancomycin clearance is associated with both gestational age and postnatal age, as well as serum creatinine, then we have a published range of GFRs, and then you can take this 400 AUC and the clearance and come up with dosing of anywhere from 24 to 80 milligrams per kilogram per day. And if you convert that into dosing schedules, that's somewhere between 12 milligrams per kilogram every 12 hours to 20 milligrams per kilogram every 6 hours. So what you'll find when you read most publications in neonatal drug therapy, the dosing per day is roughly 40 to 60 milligrams per kilogram per day, which is right in the middle of this range. So that's pretty solid. You're not going to, but again, it's going to show that TDM is very important. But are these targets, these AUC-MIC targets, are they associated with an increased risk of nephrotoxicity or ototoxicity? We don't think so, but we don't know. The toxicity appears to be related more to underlying disease state and the concurrent use of medications such as furosemide and gentamicin. Some adult studies show an increased toxicity with an AUC greater than 600 and or with higher trough concentrations. So this is an even newer concept than the unbound concentration. What about unbound concentrations and target AUCs? So we're going to do the math again. So if a target AUC of 400 in adults is efficacious, should we make this the same target for neonates? Remember, this is based on total drug concentration. So an AUC of 400 total in adults would be an AUC of 248 if you used unbound drug, because their unbound fraction was 62%. We'll go back and we'll say, okay, so if you use a 248 unbound AUC and convert that to neonates because of less protein binding, now all of a sudden our AUC target is 275 instead of being 400. This has never been tested for clinical outcomes. These are new concepts in the last year or so. But there was concern in the past that perhaps our older dosing of vancomycin was not high enough. When you use these newer concepts about AUC and unbound drugs, perhaps our old dosing was not so bad after all. And if you try and look at older studies and outcomes versus newer study and outcomes, you really can't compare them. There aren't studies like that available. So this is a concept, but it's not been tested for clinical outcomes. In summary, trough concentrations are often poor predictors of area under the curve. Trough concentrations associated with an AUC greater than 400 are lower in neonates than in adults. And conceptually, the target of 400 in neonates may be unnecessary because of the higher unbound drug concentrations. Those places that have pharmacologists and Bayesian software available, you can calculate AUC using one random drug concentration. So the purpose of a TDM program in a hospital would be using this Bayesian software and therefore only needing one random drug concentration instead of multiple drug concentrations. But we have no clinical outcome studies in neonates either using the area under the curve or unbound vancomycin. Those are yet to be determined. Some people are recommending intermittent dosing, recommending continuous infusions rather than intermittent dosing. If you are going to use a continuous infusion, you need to use a loading dose. Otherwise, it will take you too long to get to a therapeutic level. And if you're going to use a continuous infusion, measure steady state concentrations 12 hours after the loading dose and then adjust accordingly. All right, lastly, we'll talk about metronidazole. It's not approved for use in children, but it's often used off-label to treat anaerobic intra-abdominal infections. Why is it off-label? Because the metabolites are thought to be cytotoxic and carcinogenic in rat models. You need to remember that metronidazole is a prodrug with extensive hepatic metabolism. The hepatic metabolism is through 2A6 and it has 5 metabolites, some of which are active. And we know that this 2A6 activity actually increases in neonates after 2 weeks of age. Dosing recommendations that were in the literature prior to 2012 were found to be suboptimal for older and more mature preterm infants. We know from pharmacodynamic studies that there is metronidazole activity for 12 to 24 hours after administration, and there is a post-antibiotic effect that extends 3 hours beyond after the concentration falls below the MIC. So the concentration-dependent bactericidal activity, the prolonged half-life, and the sustained activity in the plasma support the idea of using higher doses given less frequently, similar to the aminoglycosides. Nonetheless, neonatal studies have been using surrogate pharmacodynamic targets of steady-state trough concentrations greater than 8 micrograms per ml. Here's a graph looking at metronidazole clearance versus postmenstrual age, and you can see it's pretty constant up until about 30 weeks, and then it becomes quickly linear after that, and clearance changes a lot. So I took 3 studies. This is from 2011, 2012, and 2017, and these are the current recommended dosing. So it's 15 milligrams per kilogram loading dose for all babies, and then a maintenance dose that's usually 7.5 milligrams per kilogram, although in this group it's 10, with a dosing interval ranging from 24 hours in the smaller babies to 6 hours in the babies who are now post-term. And I thank you for your attention. And no questions.
So thank you, Tom, again for this very important and educational lecture. As this is a webcast talk, we do not have any Q&A. But one thing I do hope that Tom would continue to come to Hong Kong. We just found new areas of interest. So perhaps the next trip when you come nearby, or perhaps the single destination is Hong Kong, we will meet again and invite you to this talk. Thank you very much.
Excellent.
Thank you.
Thank you.